A S-ICD senses subcutaneous signals from two sensing electrodes and from the can through three different programmable vectors. The first one is the primary vector from the proximal electrode to the can. The second one is the secondary vector from the distal electrode to the can, and the last one is the alternate from the two sensing electrodes. When you look at this X-ray, it's obvious that with these two vectors, you cover well better the ventricle than with the alternate, and that explains why in a vast majority of patients, the optimal signals are observed with these two vectors compared to this one. After implantation, the system automatically selects the optimal vector between these three, and this automatic selection is based on a combination between different parameters. The device will search for the optimal R wave amplitudes and the best ratio between the R wave and T wave amplitudes to avoid T wave oversensing. It will try to select also the vector with a QRS duration not too long to avoid double counting of the QRS, and also it will try to find the optimal vector in terms of best noise reduction. So there is a possibility of automatic selection by the device of the vector used for sensing, but there is also a possibility of manual override of the sensing vector by a physician via the programmer. When you look at this slide, you can see that far-field subcutaneous EGM recorded with an S-ICD differ consistently from near-field intracardiac EGMs recorded with an implantable defibrillator. So if you compare the intracardiac EGM with the subcutaneous signals, you can see that subcutaneous EGMs have a lower amplitude from 0.3 to 4 millivolts, but also a longer duration, and that the frequency is lower, the frequency content is lower compared to the sharp signals recorded with intracardiac EGMs. But also we know that there is a greater postural variation in the recording of subcutaneous signals. Since the amplitude of subcutaneous signals is lower, and to minimize undersensing of VF, S-ICD operates with a lower sensing floor, 0.08 millivolt compares to 0.3 or 0.5 millivolts in a transvenous ICD. Since the signals have a lower frequency content, the device will use a lower high-pass filter, so 3 Hz compares to 14 to 20 Hz in an intracardiac defibrillator. Since the duration of the signals is longer, the device will use longer post-sensing refractory period to avoid double counting of the QRS complex. So in a subcutaneous ICD, the post-sensing refractory period will be between 160 milliseconds and 200 milliseconds according to the heart rate. Looking at this slide, you can easily understand why there is an increased risk of oversensing of the P wave and the T wave with far-field sensing of subcutaneous signals from very distant electrodes compared to recording of an intracardiac near-field signals, where in most of the patients you will only sense one sharp signal corresponding to the QRS. You can also understand why during a tachycardia you will have a good possibility of discrimination of the origin of the arrhythmia based on the change in the morphology, because most of the time the changes on the morphology of the signals are much obvious on far field signals compared to near field signals.